Hello everyone, and welcome to the Older People and Frailty Policy Research Unit's YouTube channel. Today we'll be looking at the webinar from the 11th of November 2020, focusing on the rapid response research insights from COVID-19. We'll be separating this into three main topics. The first one, presented by Dr. Gemma Spears, will look at measuring frailty in younger populations and using the clinical frailty scale in intensive and critical care settings. Secondly, Dr. Liz Bolton will be presenting their research on which befriending, social support and low-intensity psychosocial interventions delivered remotely are effective in reducing social isolation and loneliness among older adults. And finally, Dr. Lisa McGarrigle will be presenting their research on digital technologies for fall prevention amongst older adults during COVID-19 home isolation and physical distancing. To skip to any one of these, click on the timestamps in the description or use the stamps presented. Without any further delay, we shall start with Dr. Gemma Spears.
So I'm Gemma, I'm from Newcastle University, and I'm going to talk about some work that we did earlier this year. Next slide, please. So we were asked by NHS England to undertake a rapid review of evidence about measuring frailty in younger populations. And this work came about because there was interest in whether some younger populations could benefit from being classed as frail in order to shape their care. But because frailty is typically assessed in older populations, this presented some questions around how is frailty measured in younger groups and are there any validated tools to do this? And also, is there any evidence about whether assessing frailty in younger populations actually has any impact on patient care and outcomes? So we undertook a rapid review to answer these questions, which we started in January. And then a bit later in March, when the pandemic began to kick off, we were then asked to do a rapid response piece of work that was embedded within this review. And this was to look for evidence specifically about using the clinical frailty scale with younger populations in critical care settings. Next slide, please. So I'm going to summarise the main findings from this work. I'm not going to detail the methods here, but a key point to note is that we defined younger populations as those aged under 60 years. Next slide, please. So first, we didn't find any measures that were designed and validated to measure frailty specifically in younger populations. The evidence that we found came from studies that were measuring frailty in samples aged under and over 60 years and using the sorts of tools typically used with older populations. We also found evidence that some measures of frailty demonstrated predictive validity in samples that included younger populations. However, we do need to be cautious about interpreting this evidence. It's unclear to what extent these measures are actually valid across the whole adult age spectrum. And this is because most studies didn't stratify their analyses by age, and most of the studies were using samples that were aged on average over 40 years. We also need to be cautious about interpreting this evidence because studies were using samples aged over and under 60 years. So although there was evidence of predictive validity, we don't know to what extent this was driven by potentially greater prevalence of frailty in the older sample participants. So yes, some measures did demonstrate predictive validity in samples that included those younger populations, but we just need to be careful about how we interpret this. And finally, we found no evidence about the impact of assessing and measuring frailty in younger groups. There was some speculation in some studies about how assessing frailty could benefit patient care, but we didn't find any studies that actually evaluated this. Next slide. In terms of the rapid response work, we found a systematic review published in 2019 and 7 primary studies that looked at the use of the clinical frailty scale in younger populations within critical care and intensive care settings. The systematic review concluded that although the clinical frailty scale is widely used in critical care settings, there's limited evidence about its reliability. We also found mixed evidence across the primary studies about whether the clinical frailty scale could predict ICU and post-discharge death. And there was no evidence about the use of the clinical frailty scale as a triage tool in younger populations. Next slide, please. So to pull this together, there are 2 key takeaways from this work. first, although there is interest, clinical interest in particular, in assessing frailty in younger populations, we do need more evidence about the validity of measures to do this. And we also need evidence about the impact and utility of doing this. The second key takeaway is more of a conceptual question. Is frailty the same in younger and older populations, and therefore can you measure it using the same sorts of tools? This isn't something that we could answer here, but if policy does wish to pursue extending frailty assessment to younger populations, then this is a really important question to explore. So I'll leave it there. I'm happy to answer any questions. If you are interested in knowing more about this work, the full report is published.
Thank you very much, Dr. Gemma Spears. The full report can be found in the description below. Our next speaker will be Dr. Liz Bolton.
I'm going to be talking about a piece of work which we conducted in partnership with the Epicentre, with colleagues based at UCL and also at the people at the University of York. So next slide, please. So at the beginning of the pandemic, the government put out a call for NHS volunteers to make telephone calls to isolated older adults. And whilst this was a positive move, we did have concerns about how that would be delivered. And befriending and other community support services usually have systems and processes in place to support the volunteers delivering support, as well as those receiving the support. And in March and April of this year, support services that had been delivered face-to-face were switching to remote delivery. So we aim to conduct a review of remotely delivered befriending, social support and low intensity psychosocial interventions, which were aiming to address loneliness or social isolation. And we felt the findings would be used to recommend how to structure these services to ensure that they were delivered well. Next slide. So we developed a robust search strategy and found 5 reviews that met our criteria. I'm not saying a lot about that now, but you can always ask me. We conducted a narrative synthesis of the findings, as well as 2 processes called intervention component analysis and qualitative comparative analysis, to understand the ways in which the interventions were effective. The 5 reviews looked at the relationship between technologies used for communication and social relationships, psychological well-being, social isolation, and social connections. Next slide. So summarising the findings of the narrative synthesis, we found that supported video communication interventions were regarded positively by older adults, with evidence of decreases in feelings of loneliness and increases in social support scores. Telephone contact was used in only 2 studies, with qualitative findings showing reduced feelings of loneliness and social isolation, with older adults feeling more connected to others and feeling more able to cope. The online discussion groups and forums showed mixed results, with some increases in social support, but limited reductions in loneliness, and 4 studies didn't measure loneliness at all. Next slide. Social networking sites we found have the potential to reduce loneliness in older adults, but the evidence here is weak. Older adults appeared to value fewer, stronger connections with others on these sites, as opposed to many weaker ties. And multi-tool interventions, by which we mean the provision of a PC with training, messaging functions and chat groups, demonstrated significant decreases in loneliness, but not always increases in social support. But the nature and the content of the interventions varied, so it is quite difficult to isolate the effective elements of those. And the concepts of loneliness and social isolation varied between the studies, making comparisons and conclusions challenging. Next slide. So summarising the findings of the intervention component analysis and qualitative comparative analysis, these processes helped us to identify some key characteristics of the interventions which were effective in developing social support. So firstly, supporting the development of close relationships where participants could express feelings freely, without self-consciousness, through opportunities for unstructured discussions with their peers. Supporting interactions through ensuring participants shared experiences or characteristics, so for example being a carer or a stroke survivor, women only, or people with a similar age or socioeconomic status. And supporting interactions through pastoral guidance, for example a light touch oversight of a discussion forum by a professional, or opportunities for participants to contact professionals for advice. And successful interventions tended to ensure that all three of these characteristics were present. Next slide, please. There were other processes which we found may be important as they were more frequently observed in the successful interventions. So ensuring that participants felt their participation was beneficial for others as well as themselves, that they have a stake in the intervention design or the way they can participate, and that participants can communicate through different channels and temporalities, so real-time and asynchronous chat. And taken together, we feel that these can serve as design principles for future interventions. Next slide. So overall, the results suggest that older adults can be empowered to support each other through online discussions and forums, and that we should challenge the assumption that older adults always need to be on the receiving end of an intervention to address social isolation and loneliness. The studies that enabled older adults to feel that their contributions could improve the outcomes of others tended to be successful. So recognising that older adults can be both providers and recipients of support simultaneously is likely to be an important design principle. Next slide. So thanks very much, and we've included the link here to the summary, and the full report will be available very soon. Thanks.
Thank you very much, Dr. Liz Bolton. The full report can be found in the description below. And finally, we have Dr. Lisa McGarrigle.
Hi everyone, I'm Lisa McGarrigle, a research fellow with the Healthy Aging Research Group in the University of Manchester. And today I'm going to talk you through a briefing paper we prepared for the Department of Health and Social Care earlier this year. Next slide, please. So with the COVID-19 pandemic, there is some concern that stay-at-home measures to reduce transmission of the virus is going to have adverse effects on older people's levels of physical activity. And this could result in deconditioning and an increased falls risk. So in April, we prepared a briefing for DHSC on the potential use of digital technologies to increase physical activity during COVID-19. So this work predominantly drew on two pieces of work that were underway at the time. And the first was a review of reviews on the effectiveness of mHealth and eHealth technologies in the promotion of physical activity. So basically interventions that were delivered or enhanced using mobile applications or the internet. The second was a rapid review of apps and websites with the potential to support older people to engage in strength and balance exercises independently in their own homes. Next slide, please. So the review of reviews firstly, what we did here was we prepared an evidence summary based on 4 high quality reviews. 3 of them were systematic reviews with meta-analysis and 1 a systematic review. The interventions included wearable motion sensing devices that tracked physical activity levels, so things like accelerometers and pedometers, as well as apps on smartphones or tablets that generally synced with wearable devices. We found that there's evidence that activity monitors are effective in increasing physical activity levels. Evidence for the effectiveness of apps, however, is perhaps less clear as many studies were underpowered. However, the results did reveal trends for a positive effect of apps on physical activity levels, sedentary time, and also physical fitness. So overall, activity monitors and apps did appear to be acceptable to older people. And there's evidence that people do adhere to their use, at least in the short term. Next slide, please. So our Map the Apps review was a rapid review conducted to identify and evaluate apps and websites that might have the potential to support older people to engage in strength and balance exercises. And this would have been independently at home. So we evaluated 13 apps and 24 websites, and we assessed the current evidence base for each of these. We conducted quality assessments in relation to their content, and we evaluated the use of behavior change techniques in each. So based on this evaluation, we are able to recommend 4 apps and 6 websites listed here to older people or healthcare professionals who are looking for substitutes to face-to-face delivery of strength and balance exercise classes. Now, it's important to note that at the time of the review, there were no RCTs or other evidence for the effectiveness of any of these apps or websites in falls prevention. However, all of the recommended apps and websites do demonstrate exercises that have been used in evidence-based falls prevention programs already. So programs like Atago or FAME. Next slide, please. So finally, given the current restrictions to face-to-face exercise classes, it's very likely that digital delivery will be better than no delivery at all. It's important to emphasize that this is a rapidly changing area, and the apps and websites we've recommended here might change in the coming months, or additional resources might become available. So this research really reflects what is available to people right now. And for the immediate future, these resources could be useful for those who are already familiar with strength and balance exercises and have been previously receiving face-to-face delivery. Also, those who are relatively healthy and are comfortable with using technology. And on this point as well, consideration must be given to the fact that older and disadvantaged sectors of society might be less likely to have experience with such technologies. And so these groups might not be as easily reached using these kinds of interventions. And finally, these kinds of resources might also prove useful in a rehabilitation context following a hospital discharge, where the use of digital technologies could be perhaps explained face-to-face to the patient in hospital prior to discharge. So I'll leave it there.
Thank you very much, Dr. Lisa McGarrigle, and a special thank you to Dr. Gemma Spears and Dr. Liz Bolton for their presentation today. As mentioned throughout, the reports can be found in the description. And that concludes the presentation today, and we look forward to seeing you at the next webinar.